Hi, everyone. I'm Dr. Marie Varnett. I'm a resident in my final year of training of neurodevelopmental disabilities at UT Southwestern. I'm really excited to be here. I'm going to just be introducing kind of the clinical presentation of SLC6A1 neurodevelopmental disorders. It's strange following Lindsay. I feel like she did such a good job already talking about all of this, but we will go ahead and get started. Okay, so I don't want to preach to the choir in this room, but I will start off by just kind of setting the scene. The gene SLC6A1 is located on chromosome 3 and codes GAT1, a widely expressed GABA transporter. When GAT1 is not present, there are effects both directly postsynaptically and extrasynaptically due to higher levels of ambient GABA, or the GABA that is just always kind of around and not getting cleaned up properly. When there is too much ambient GABA, the GABA receptors become desensitized and neurons and interneurons involved do not communicate efficiently, especially in times of sustained neuronal activity. When GABA sensitivity is decreased, the fine control over network excitability is diminished. The patterns necessary for information processing and motor movement coordination are disrupted. The balance of neuronal excitation and inhibition is thrown off by increased ambient GABA and aberrant GAT1, generating discharges that will interrupt proper information flow. The amount of GABA uptake activity that is disrupted in SLC6A1 is determined by how much function GAT1 retains, and lower GAT1 function leads to more severe symptoms. Level of GAT1 activity varies by the variant involved and where that variant is located within the protein structure, especially those that are located around sites important for GAT1 trafficking to the cell membrane and interacting with GABA. Variants that cause symptoms so far identified are essentially all loss of function. Most are missense, but a not insignificant amount are nonsense and frame shift as well. Loss of function may be complete or partial. Those with complete loss of function seem to have more severe symptoms. So SLC6A1 neurodevelopmental disorders are just relatively recently described, first in 2015, and increasingly recognized as a cause of epilepsy, developmental disability, autism, and now with an estimated prevalence of 1 in 38,000 births. In 3 large-scale genomic screens of epilepsy, SLC6A1 was found to be in the top 10 to 20 genes with the highest pathogenic variants. And in the largest exome study of neurodevelopmental disorders, pathogenic variants in SLC6A1 were highly enriched and within the highest confidence of disease-causing genes, ranking at 51 for one of the most, for the top genes associated with autism. Okay. So these are the areas that I'll be briefly covering today. Each topic on its own could be its own lecture. So I won't be able to cover the entire breadth of SLC6A1 NDD, but instead this will be more of an introduction. Much of what I'll be talking about today will be from the data we have been collecting through our natural history study and through our combined retrospective review that we've been doing with CHOP. Okay, so I am going to set the stage with a sample case. So a 2-year-old girl presents to the neurology clinic for delayed development and abnormal spells. She was born on time with no complications after normal pregnancy. She had many issues with reflux as an infant, and parents struggled to find a formula she could tolerate. She never seemed as interested in toys or her environment as her older siblings. She was mildly delayed in sitting up, crawling, and walking, but now at the age of 2, she can walk and run. However, she seems less coordinated than her peers. At times, she will fall suddenly without clear cause. Since infancy, parents have noticed odd episodes of blinking and staring. She has previously had an EEG around 10 months of age that was normal. Cooing and babbling were on time. She said her first word a little after 1 year old and gained a handful more words, but over the last couple months have stopped speaking altogether. Tantrums occur just like any 2-year-old. However, parents feel that her outbursts are more intense and difficult to soothe compared to their older children. Okay, so first we will go over seizures and movement. So there are many similarities in the events concerning for seizures among individuals with SLC6A1 variants. Terms that frequently arise when describing the events include staring, drops, behavior arrest, eye flutters, drops with a limb jerk associated, and so on. Taking these terms and translating them into ILAE classification is not very straightforward, especially when many of the events don't actually have an EEG correlate and may be a stereotypy, a movement disorder, or a tic. For example, eye flutters, eye blinking, and eye rolling descriptions are very common. They are described in some form in the majority of children with SLC6A1. They may all be part of an absence seizure, could represent eyelid myoclonia, or be a particular repetitive behavior of the child. When looking at the events that could be classified, absence seizures were far and away the most common, with nearly every child with epilepsy experiencing absence events. Atonic was the next most common, followed by myoclonic atonic at about 28% within our cohort who had seizures. We jumped ahead one, so hopefully y'all were able to see that last graph okay. Oh, there we go, but now we're okay to move on, sorry. Even though concerning events may emerge around or before a year old, usually consisting of drops, staring, and/or eye flutters, early EEGs are often normal and become abnormal with age, and eventually patterns consistent with absence and atypical absence epilepsy emerges, as well as increasing rhythmic delta. I'm not going to go into too much detail because right after me, Dr. Searcy will be going into more details about EEGs and quantitative analysis. When considering how to treat seizures in SLC6A1, there are medications that tend to be more efficacious, and it seems like, and I don't have any analysis to back this up at this time, that if they're unable to achieve seizure control on a couple of medications, then they're more likely to have refractory epilepsy. Unsurprisingly, Keppra is the first medication tried in most cases. It is effective in some, but for most, it's either ineffective or behavior side effects are too severe to continue that medication. Valproic acid works about as well as Keppra alone, but tends to do well in conjunction with something else. However, when it's not tolerated, it's often due to increasing seizures and increasing behavior concerns. Clobazam is also an effective medication and is generally better tolerated than Keppra or valproic acid. Another nice thing about clobazam is that because of its pharmacology, it can be given as a single dose at night to help with sleep problems. In general, delays in development and lower IQ are associated with decreased motor skills, and children with autism may have atypical patterns of gait and reach regardless of their cognitive level. Abnormalities in movement and muscle tone are frequently described in the SLC6A1 community, with 44% of caregivers in our cohort describing their children as clumsy or uncoordinated. They may not be able to keep up as well during physical activity or may have tremors and abnormal gait. It is hard, though, to capture movement abnormalities that can be difficult to explain or notice. In addition, stereotypies were very common, reported in 72%, even without an autism diagnosis. Additionally, hypotonia is often described in infancy and frequently persists as mild hypotonia as the child ages. The hypotonia can lead to feeding issues and complicate motor development. When present, it is often one of the things that prompts presentation to care. Developmental coordination disorder questionnaires were administered to the 20 natural history study participants, and of those, 90% were able to be classified as probable developmental coordination disorder. Even in participants without autism or intellectual disability, their DCDQ score was more likely to be lower than their age-matched peers, often with abnormalities in muscle tone or clumsiness. Those with myoclonic seizures were likely to have lower scores in fine motor and gross motor subsections, and a later age of seizure onset was associated with a better fine motor score. Okay, going back to our sample case, Because you're worried about the description of the events she's having and developmental regression, you begin your workup. Routine EEG was abnormal. Whole exome sequencing returned with a pathogenic variant in SLC6A1. I'm sure you're all very surprised by that. Next, we'll be going on to development. GABA homeostasis contributes to brain development, guiding neuronal maturation, synaptogenesis, and encouraging neuronal networks to form. The grand majority of those in our cohort have some developmental delay, and in about 40%, there's also developmental regression. When looking closely at our natural history study participants, there was a split evenly between regression in language and motor skills. As I will detail more in a little bit, adaptive skills are also affected, even if the threshold for intellectual disability is not met. ID can be severe, but in the participants that we had confirmation of an ID diagnosis, it ranged from mild to moderate. In a previously published paper by our group, looking at regression patterns in our natural history study, 3 patterns of regression were described: a single episode without recovery, a single episode with recovery, and multiple episodes with recovery. When there is regression, those individuals are also more likely to have seizures, autism, and/or a severe language impairment. However, not every individual with regression is diagnosed with autism, suggesting either that this is a feature of SLC6A1 or that these kids might present with autism in ways that are not being caught with traditional methods of diagnosis. Since regression is often related to autism, I compared the rate of regression in our kiddos with regression in autism from all causes and found that while our cohort had 40% with regression, the prevalence of regression in autism is 30% globally. This leaves us with more avenues to explore because there is something different about the development and autism in this population than in autism at large. Okay, going back to our sample case, you've been working on seizure control, which has required adjustments, but is overall going well. Because you know how important early intervention is, you sent in referrals for speech therapy, physical therapy, occupational therapy, and autism evaluation. Luckily, you live in an area with somehow little to no wait time for therapies and autism evaluation. By the time family follows up with you, she's established in therapies and they have an autism diagnosis. Families relieved to have names for what has been going on with their daughter, but remain anxious about the future. So next, we're just going to go into a few details about autism. In our cohort, 61% carried an autism diagnosis, which is much higher than previously reported. Diagnosis of autism was pretty evenly split between male and female. When a level was available, the majority were level 3 or requiring substantial support. Level 3 designation was also evenly split between genders. Where available, we were able to look at the CARS and ABAS scores. So CARS is a tool used to diagnose autism using parent reports and evaluator observation. Scores ranged from 23 to 58 with an average of 38.9, which is consistent with severe autism. The ABAS is a tool used to look at adaptive skills or how the individual is able to function in the environment around them. While lower scores were more likely to also have a diagnosis of autism, there is a decrease in adaptive abilities overall. The mean general adaptive composite was 67.9, more than 2 standard deviations from the standard population mean. Okay, back once more to our sample case. Your patient is now 7 years old. Seizures have been under control for years, but parents are more stressed and frustrated than ever due to their daughter's difficult behavior. She has frequent meltdowns that are difficult to predict. At times, she can become aggressive, both during a meltdown and sometimes seemingly out of nowhere. She is in full-time ABA, but her therapists are also unsure how to proceed. At this point, they're considering discharging her from their center. To make matters worse, your patient only sleeps about 4 hours a night. She struggles with bedtime, then wakes early, unable to fall back asleep. The parents are exhausted. Well, we're doing behavior and sleep now. So maladaptive behavior is very common in SLC6A1, and as the children grow, often becomes the biggest struggle in daily life. We have heard many times that behavior seemed to worsen as seizure control improved. In our cohort, 78% reported some maladaptive behavior, with the large majority having tantrums or meltdowns that were abnormal for their age and disruptive to their participation in family and social life. Interestingly, when tantrums are present, caregivers will often remark on their unpredictability and difficulty to soothe. Low frustration tolerance and impulsivity complicate the propensity to tantrums, but these are often present even without progressing to meltdowns. When considering disruptions in daily life, aggression is especially challenging. Often a part of meltdowns, it can also seem unpredictable and out of nowhere. When maladaptive behavior is present, aggression is seen in over half, which is higher than a previous study utilizing the child behavior checklist in 25 children. In that study, the presence of aggressive behavior did increase with older children, going from 8 to 33%. While in SLC6A1, aggression may be independent of an autism diagnosis, the likelihood of aggression in children with autism of any cause is about 25%. So both the present and previous studies surpass this. When working in the rare disease space, behavior is often not reported, or at least not reported in detail, although it can be the most challenging symptom for families. We often focus on symptoms that are easier to quantify, like seizures, because behavior is very difficult to get objective data on. Studies will often use tools that aren't validated in children or in autism, and this is a limitation of our own study. Is that aggression prevalence is commonly reported as higher when standardized tools are not used. So expanded use of behavior scales like the CBCL alongside other evaluations of development could help resolve some of these issues with tracking behavior. Surprising no one, when no one in the house is getting any sleep, quality of life will suffer. In our natural history study group, the sleep disorder scale for children was administered, and all participants scored over 39, which indicates clinically significant sleep problems. When caregivers reported disrupted sleep, this correlated to subdomains of the SDSC, namely disorders of arousal and sleep-wake transition disorders. Additionally, when subdomains of disorders of initiating and maintaining sleep and disorders of excessive somnolence both correlate with a diagnosis of autism, while severity of the latter subdomain correlated with autism level. So when that score was higher, the autism level was usually higher. Total SDSC scores correlated with the presence of behavior problems. Okay, to sum up our sample case, your patient is doing much better after a long journey of different medications, therapies, and behavior modification. You've done a wonderful job partnering with the family to address the needs of the child and caregiver. So just a few points to sum up on. So hypotonia with and without associated feeding issues and developmental delay are often what prompt presentation to care. Early events like staring and falls may not have an EEG correlate, but might respond to seizure medications. Absence, often atypical, is the most frequent seizure type. Behavior challenges should not be overlooked, as these are frequently most troubling for caregivers. Addressing sleep challenges can vastly improve the family's quality of life, and movement disorders are often as subtle as just clumsiness, but are frequent. Okay, so I just want to say thank you to my mentors, Dr. Armstrong, Dr. Goodspeed, to the whole team at UT Southwestern that's been helping with this particular effort, Dr. Cersei, Hamza, Sanjana, and Elaine, and then our partners at CHOP, especially Dr. McDonald and Lania Lusk, And then, of course, special thanks to Amber for pulling all of this together. You do so much work. And then none of this would happen without the caregivers and the participants who give up so much to be a part of this effort. And that's all I have. I don't know if there's still time for me to answer questions, but I'm happy to take any. No?